All right.
Peters.
Hi, Richard.
Hello, how are you?
I'm fine.
Sorry.
No worries.
My lab is on the way. I'm not sure exactly where they are. I think, I guess maybe in the interest of time, so the food's on its way, so apologies for that. I guess we get started, so, it's my pleasure to introduce, Dr. Elliot S.
Yeah.
He's, actually a proud alumnus of UCI. He's in his bachelor, he has a Bachelor of Science degree in genetics. And then he got his MD degree at the State University of New York in Buffalo in 2017. And after doing an internal medicine residency and then a fellowship at Medical College of Wisconsin, he came back to UCI. So now he's assistant clinical professor in the Department of Medicine. He's a part of the division of gastroenterology and hepatology, correct?
Yeah.
And he's been doing a lot of work. He and his colleagues have been doing a lot of work on advanced endoscopy and using AI for interpreting images. And so he reached out to me in October to basically to see if there's some issues and challenges that he's been observing inside the clinic, but in some of his GI work. And so he was looking for engineering collaborations. So I thought this would be a really good opportunity to try to kind of broaden the I guess basically the group of people that he'd be talking to in terms of just presenting some of the challenges he's seeing and seeing if we can come up with some solutions for some of these. And so, or, and just kind of continue the discussion. So with that, I'd like to welcome Dr. Yu.
Great. Thank you so much, Dr. Choi. Thanks, Dr. Choi, for setting this up, and appreciate everyone tuning in and listening to my talk here. So I just wanted to discuss potential pitfalls I see as a clinician, the challenges in our current modalities, diagnostic modalities. I just want to give an introduction of what the disease states we study, the current technology in which we study these certain diseases, and the limitations sometimes we face in our current technological advances. Let's see, does this go? Okay, so a little bit about me. As Dr. Choi mentioned, I did my undergraduate here at UCI. I then went to University at Buffalo for medical school in New York, and then I did my postgraduate training in internal medicine residency and stayed on for my gastroenterology fellowship at the Medical College of Wisconsin in Milwaukee. And I was hired in October to come back to UCI after a decade of training. So I'm glad to be back in Southern California. As far as the breakdown of different subspecialties in gastroenterology, one of the reasons I chose GI was that there was a multitude of organs. You're not pigeonholed into one certain organ, say cardiology, nephrology, just focused on kidney, heart, respectively. As a GI doctor, you're treating a multitude of different diseases from a multiple different pathologies of different organs. So we have a general gastroenterologist, adept at colorectal cancer screening, abdominal bloating, discomfort, constipation, diarrhea. Hepatology, liver doctors who manage end-stage liver disease when the liver gets very scarred down and can do some life-saving transplant hepatology and manage their immunosuppression by coordinating liver transplants to these patients with end-stage liver disease. Neurogastroenterology and motility, we study the peristalsis of swallowing of the esophagus, emptying of the stomach, and slow transit of the colon, and administer medications, pro-motility agents to kind of help patients with these specific issues. We have pancreatobiliary advanced endoscopists who do advanced endoscopic procedures like a gallstone removal for cholangitis infection of the bile ducts. And they also do endoscopic ultrasound where they can actually look inside the stomach with ultrasound probe on the endoscope and visualize the pancreas and liver in a little bit more high definition than an external scan. And there's our inflammatory bowel disease specialists that work pretty closely with chronic conditions of inflammation such as Crohn's disease, ulcerative colitis, and manage immunosuppressive biologics to keep immunosuppression at bay for these patients. My particular focus, I did an extra year of training in neurogastroenterology and motility with a T32 year, so 1 extra year of training. My current research interests and clinical focus are aspects of dysphagia or difficulty swallowing, gastroesophageal reflux disease, gastroparesis with delayed gastric emptying that leads to nausea, vomiting, inability to tolerate food, and abdominal discomfort. And then also working on exploring upper GI bleeding, which is one of our medical emergencies that we get called into in the middle of the night for our clinical cases. Disclaimer here, I am a physician, not a physicist, even though we share a certain amount of letters, but I'm here to kind of discuss the current problems that I face and see if we can start a dialogue and see if there's anything you guys can suggest from your standpoint from a physicist standpoint, and kind of see if we can tackle these problems together. So as far as the bread and butter of GI, we are proceduralists. All general GI doctors, gastroenterologists are trained with endoscopy, upper endoscopy that looks from the esophagus to the first part of the small intestine, the duodenum. We can evaluate for upper GI bleeding, peptic ulcer disease, look for esophagitis, evidence of reflux disease. For colonoscopy, we go through the bottom, we go through the entirety of the colon to the last part of the small intestine up to the terminal ileum. And we evaluate for lower GI bleeding, but the bread and butter is colorectal cancer screening. And it's one of the few modalities that have been shown to decrease all-cause mortality by preventing the prevention of colorectal cancer. So that's why the United States Task Force recommend everyone at some point get a colonoscopy for colorectal cancer screening. So what are some of the things that I've faced that have been some challenges to me in my clinical work? Certain aspects of localizing an upper GI bleed that can delay treatment, evaluation of gastroesophageal reflux with certain modalities that we have. There's an aspect of reflux that reaches the throat called laryngopharyngeal reflux that we still have a hard time kind of grasping and diagnosing to see if this is truly attributable to a patient's symptoms of throat clearing, chronic cough, or globus. And then with gastric emptying, it's kind of a mixed bag about whether the association of dyspepsia or stomach discomfort and bloating is related to the effectiveness of the stomach emptying. And then also, it's still somewhat of a mystery for how these inflammatory bowel disease cases kind of come on. We have good treatment to suppress the immune response, but we still don't have a quite clear picture of what causes this immune response in the first place. So for starters, I'd like to talk about upper GI bleeding first. Mainstays of causes for that are peptic ulcer disease, either from heavy non-steroid anti-inflammatory use, such as Advil, Aleve, things like that. You can have a bacteria in your gut called Helicobacter pylori that can create ulcers in your stomach, causing bleeding. Certain people who heavily drink with excessive vomiting and retching can actually tear a part of their esophagus, leading to bleeding as well. And in certain people with end-stage liver disease, there is scar tissue in the liver that backs up venous flow into the esophagus that can spontaneously bleed from high pressure gradients. And there can also be hidden vessels within the stomach that can spontaneously bleed in the submucosa of the stomach.
So from a diagnostic point of view, is there any value in knowing if the reflux gets up into the mouth during sleep? Is there value to knowing?
Yeah, so there's certainly a nocturnal component to that. When people come into the clinic, they have this globus sensation, a stuck sensation in their throat, chronic cough, throat clearing, and there has been associations with acid getting up to the throat, but it's difficult to prove that. And I'll talk a little bit more of that about how we study that. For upper GI bleeding, this is a case I saw in my fellowship. Basically, a guy in his 60s came in with diffuse bloody vomit, kept vomiting, retching, had to be intubated for airway protection. We did a CT scan, and this is a visualization of his stomach in the axial slice. The top part of the front area is on the top, back part is the spine. You can see the stomach just full and distended with blood products clot. And you get a better sense of that on the coronal image on the right side, that the stomach is so distended with blood. So we go in there, we try and fix that. Oh, my pictures didn't show up. Oh, there we go. So when we get in there with our endoscopy, this is in the stomach. I can't see anything. It's full of clotted blood. We try and pull back. At the end of the stomach, there's just retained food. And when I pull up to the esophagus, we may have saw an ulcer there, but we can't really see if it's actively bleeding underneath this bed of clot. So we couldn't really visualize the active bleed at that time. And so we had to actually wait and come back and clean out the stomach with promotility agents before we could get a good visualization of the bleeding. So how does this happen? When people have liver disease or scar tissue of the liver, you can get a certain backflow into your esophageal veins. Normally, the liver is the detoxifier of your body, cleans out ammonia from the venous blood before it returns to the cardiovascular system to get reoxygenated with blood. You can kind of see the portal vein leads into the liver, but if the liver is very scarred down, you get a resistance of flow, and that's pushed back into the proximal vessels of the left gastric vein, which feeds these esophageal veins. And that is what caused the patient that I had to vomit excessive amounts of blood, because these variceal bleeds blew because of the high pressure gradient. And it's regarded as a medical emergency because this bleed will most likely not stop because of that high pressure gradient from that scar tissue of the liver. So it's our medical emergency in the GI world. Of course, it's not a heart attack or a stroke, so we do have some time, but it's recommended by our guidelines to treat this within 12 hours of presentation. And it usually doesn't stop by itself because of that portal pressure gradient being high pressure. So what we do is when we see these engorged veins, we have a rubber band ligator, which we put like on a cap on our scope, and we band these vessels to tamponade the vessels. So we kind of squeeze them off, choke them off, so they tighten up and stop that blood flow from going to the esophagus. And this, on that picture on the right, is what you see after I banded a different individual in a case that I could visualize the bleed. And those eventually shrink down, they fall off, and they get some ulcerations, and then we check back every a month or so and make sure they're eradicated and reband if necessary. If we can't localize the bleed, then we have to turn to our interventional radiology colleagues. They actually do a shunt procedure where they bypass this high gradient flow in these sinusoids on the top. My pointer isn't working here. Okay, can you see the mouse? I don't think you can see the mouse. No. But the sinusoids are where the scar tissue is, so there's a high pressure gradient here. What the IR folks do is they make a shunt to bypass the scar tissue and get to the end of the venous flow of the liver to curb that pressure gradient. However, it's a double-edged sword because the liver detoxifies, removes ammonia from the body, but you're not removing that ammonia because you've shunted the blood. And thus people can get hepatic encephalopathy confusion when that ammonia crosses the blood-brain barrier, causes them to be confused. So if I can't localize the bleed, we may set them up for the shunt procedure, but that takes time. And if this patient is actively bleeding, very tenuous from their vitals, we need to tamponade it. And to get them to that point, we have this Minnesota tube with a gastric balloon and an esophageal balloon. This is not a picture of a football player. We actually have a football helmet in our hospital to tie off this balloon to provide traction, to pull up this gastric balloon in the stomach to tamponade those vessels from bleeding. Stays 24, 48 hours. If I don't have this football helmet, we tie it to an IV pole to put traction on it, to buy us some time so the IR folks can do that shunt procedure. But that's my first pitfall. If we could have identified this bleed from the first endoscopy, would this have been necessary? If I can't localize the bleed, there's delayed treatment, increased hospitalization time. The current modalities that we have is we can use a therapeutic endoscope. It has a larger suction channel, but this is coagulated blood. Even if I keep sucking it, it's going to clog the channel eventually. And we can come back, we can give prokinetic agents such as erythromycin that can stimulate the stomach to push out the blood, but that takes time, and we have to come back in 24 hours to relocate the bleed. So currently, right now, our endoscopes, there's two main brands, Olympus and Fujifilm. We have high definition white light endoscopy from 400 to 700 nanometers. We have an option to do this narrowband imaging. The other component of the propriety is blue light imaging with Fujifilm, but essentially isolates the wavelengths to be blue light, low diameter, low nanometer technology to highlight the blue light in certain visualization of the endoscope. And right now we employ this to identify high-risk polyps during colonoscopy. So white light is on the left, NBI is on the right. You can kind of see it enhances some of these certain features. The adenomatous polyps, which can potentially become colorectal cancer, look more like a little brain here. It enhances the blood vessels in there and looks more brown in relationship to the remaining mucosa. The ones on the top are adenomatous polyps. The ones in the middle are serrated polyps. Both can be precancerous. And the bottom one is a cancerous lesion. that has deep invasion to the submucosa. Another example of that is defining benign versus precancerous polyps. When we do it under NBI light, looking at the blue wave wavelengths, we can see a benign polyp doesn't have those features of an adenomatous polyp in that middle picture, but the benign polyp is on the left and doesn't have those features, while the cancerous polyp looks very irregular. It loses that circumscribed formation and has this irregular formation of vessels. So one of my thoughts is with this upper GI bleeding, can we use some form of like thermal imaging, infrared technology to be able to identify a high vessel exsanguinating bleed based on temperature? If we could locate that, we could place a clip on it, try and identify a bleed without having to go through all this bed of clot to take care definitively this active bleeding source. So one of the hobbies I have is kind of building computers. I make these small form factor PCs, and because of that, it generates a lot of heat. They've kind of commercialized the technology to kind of identify hot spots in certain areas of computer hardware when they run. And I'm wondering if we can apply that to endoscopic imaging in the stomach to localize a bleed. At UCI, in Orange, we do have an animal lab where we've looked at developing different endoscopic techniques. And one of my colleagues actually studied tying off the end of the stomach with a pylorus and insufflating the stomach to see how the sphincter of the esophagus relaxed to that. So I can easily see doing an idea with a pig stomach, for starters, as like an ex vivo study to see if this is a potential feasible approach. So that's one of the ideas I had.
So just to be clear, you're trying to see
Yeah.
the active bleeding below the clot.
Below the bed of clot, and see if we can identify it without needing to suction, clogging up my scope, without that need of delay for tamponading the bleed and needing that shunt procedure, because those do take time.
I'm sorry.
Mm.
Is it okay if we interrupt?
Yeah, yeah,
You
please.
want to brainstorm, I can't help it.
Yeah, of course, go. Go
If
ahead.
we can make it so the suction never clogs,
Mm.
is that close to solving your problem, or is it the baby step in the wrong direction?
So, I mean, if we can suction out all the clot ideally, but it's a very small channel. Like the scopes themselves are like 9 millimeters in size, so it's like a fraction of that. And even with the therapeutic scopes, even with the bigger channel, they do get clogged up on occasion. Yeah, yeah. So they've actually developed a over tube with more channels and wider suction. And we use it for unprepped colons, but it does take time as well to clean. It's not for upper GI bleeds yet. It's more for colonoscopy preps, but that technology is commercial right now.
Do you have an idea of bleeding source and the surrounding clots?
Yeah.
What possible the temperature difference? Would it be 1 degree Celsius?
Yeah. So not quite clear, but if it's gotten to the point where it's been completely coagulated, I assume that blood is a little bit less temperature than an actively ensanguinating vessel with fresh blood going through. So that's something that to be potentially hammered out in a proof of concept study to see if this is actually feasible based on temperature.
Possible or more clinical available technique with the indocyanine green fluorescent treatment.
Okay.
Fluorescence treatment is for intestinal bleeding. This idea food.
Yeah. Yeah, so we use like the tagged red blood cell scan. We also use CT angios to kind of localize a bleed. But it's kind of hard to correlate that when you're actually in the endoscope to kind of see where exactly that bleed is. Because when we try and place a clip or apply heat to stop the bleeding, we have to kind of visualize to see if we've actually stopped the bleeding at that point. So it's a little bit tricky to correlate a CT finding of a blush that you see with the endoscopic findings in real time. Okay. All right. That'd be great. All right. So next thing I'd like to talk about is gastroesophageal reflux disease. Patients come into my clinic, heartburn, regurgitation, sour taste, and it's believed to be from relaxation of this lower esophageal sphincter that allows stomach contents to get the esophagus and cause irritation. We do have good medical treatments, proton pump inhibitors, and H2 histamine receptor antagonists. And what they do is they suppress the acid secretion in the stomach. So when reflux happens, it's less acidic and less irritating to the esophagus. But sometimes that's not sufficient enough, and they need an anti-reflux surgery procedure to actually tighten up the wrap and wrap at the end of the stomach to keep a physiological barrier of reflux from getting into the esophagus. So why do we care about reflux disease? In people with chronic acid exposure to the esophagus, people can get what we call Barrett's esophagus. And the word that the pathologists use is metaplasia, where part of the esophagus lining starts resembling the stomach mucosa just because of this chronic exposure to acid. And this has been linked to increased risk of esophageal cancer. It's low, 0.1 to 0.3% per year, but it's cumulative every year. You have a risk of 0.3% if you have Barrett's to progress to dysplasia, abnormal cancer cells, and possibly esophageal cancer. And when we see Barrett's, we do recommend screening them if we see that every 3 to 5 years if we do see that. In terms of our current diagnostic modalities to assess for reflux disease, we have 3 mainstays of diagnostic therapy. Manometry, which assesses for esophageal pressure, how well the esophagus squeezes. The pH reading, how acidic the reflux comes up to the esophagus. And impedance, which is a measure of electron flow. We can actually measure how far liquid bolus comes based on the impedance level that we detect on our sensor probe. As far as the esophagus itself, it's a tube 25 centimeters long. The distance from the mouth to the stomach is about 40 centimeters. You have 2 sphincters that separate the throat from the esophagus, the upper esophageal sphincter, with striated muscle of the cricopharyngeus and the constrictor muscles. These are the same muscles that are in your biceps and triceps, the voluntary muscles. But after you get to the distal third of the esophagus, the rest of the GI tract is lined with smooth muscle, involuntary muscle governed by the enteric nervous system. And that lower esophageal sphincter separates your stomach and is that mainstay of your reflux barrier. And that's composed of your diaphragm and the intrinsic tone of your lower esophageal sphincter, the smooth muscle of your lower sphincter. On endoscopy, we can kind of see evidence of reflux based on the Los Angeles grade classification. We see these breaks. I can't point it here, but it's A through D. D is the most severe, where you see this redness erythema involving multiple areas, confluent areas of the esophagus, while L grade A, you only see this little red break. But these are signs that there may be acid reflux getting into the esophagus, leading to damage. Our pressure catheter, the manometry catheter, has 36 pressure sensors and 18 impedance sensors. We insert it through the nose, we numb up the nose, and we slide it into the esophagus, and we have the patient swallow saline boluses to see how well the esophagus contracts as a result of that. And we have these Klaus plots that are produced from the manometry study. So spatial temporal plot, if you can kind of imagine a topographic map, you can see a sense of the elevation of a mountainous region based on a 2D image. So x-axis is time, y-axis is the sensor position, and the color denotates the strength of the contraction. Red is warm pressure, blue being cold pressure. And this is how it looks on the manometry report of a normal swallow. You get this 2 bands of pressure. Red is hot pressure, high pressure of the upper sphincter that separates your pharynx from your chest, and your chest to your stomach of your lower esophageal sphincter. When you swallow, your upper sphincter relaxes, it becomes blue to allow food to pass through. Then your esophagus takes over to squeeze that bolus, that high pressure, down the esophagus over time, which is why you get this diagonal picture, and the lower esophageal sphincter relaxes to get into the stomach. We believe that reflux is motivated by these transient lower esophageal sphincter relaxations, which can be seen on manometry. It's a vagal-vagal reflex in response to the distension of the stomach. So your stomach is very full. You vent the gas by the pressures in your intergastrum. And we record this about 10 to 45 seconds of this prolonged lower esophageal sphincter relaxation. In that time frame, reflux, it can get up to the esophagus potentially, and maybe even to the throat if it's very robust.
Oh, in other words, the sphincter relaxing the outlets.
Yes. Yeah. And so in addition to manometry, we have pH testing. There's 2 ways we can do it. We have this pH catheter that goes to the nose. It's attached to a sensor where people can denotate when they're having heartburn, chest pain, and then we go back and look if that correlates to an acid event detected by the probe. In newer technology, we have this Bravo wireless capsule, which is a capsule we place during endoscopy. We clip it to the end of the esophagus, and it has a pH probe there that can stay longer than this catheter through the nose and records for 4 days. It gives us more data, but we're kind of tied because it only has 1 sensor here, while this probe has impedance sensors and a distant 2 pH probes to detect the proximal extent of the reflux. So the Bravo tells us yes or no, we see reflux in the esophagus, but this impedance catheter can tell us the distance of how far it travels up. So this is how an acid reading is produced from the Bravo test. An acid event is divided as a pH less than 4. This line below that blue line where that red dot is on the left is a pH less than 4. Anytime it dips under that level, that's an acid event that came into the esophagus. And we define that as an acid exposure time of greater than 6% is pathologic for acid reflux. So these are procedures that can give us data, but it does take time to record this data, and patients have to be off their medication to get a baseline. So they're feeling pretty miserable if they do have fluid heartburn with that. One of the things that some Japanese gastroenterologists have been doing, they've been kind of looking to see if there's adjunct measurements of assessing for a patient's risk for reflux disease. They've attached a pressure catheter that goes through the working channel of the scope and measures the pressure wave of how the stomach pressures are responding when they insufflate the stomach with CO2 gas. And they're trying to correlate that. If they insufflate the stomach to a certain point, does that sphincter open up to vent the gas? And during my fellowship, I tried to look at this as well. In addition, instead of using that catheter to the working channel, I attached an external manometer with parafilm to my endoscope and tried to flip over and see if I could correlate intragastric pressure to relaxation of the lower esophageal sphincter. And when I could visualize the lower esophageal sphincter, I got some pretty good reproducibility. Blue is when I saw the gastroesophageal junction opening in this particular patient. And at a certain threshold, we get a peak max, and then the sphincter opens afterwards. And it's pretty reliable at a certain extent of the pressure around 20 or so when I saw this lower esophageal sphincter relax. But in certain patients, they have a hiatal hernia, which is when the stomach slips past your diaphragm and ends up in your chest cavity. And so we can kind of diagnose a person's risk for a hiatal hernia by looking at their endoscopy. If it's tight to the scope, probably less likely they have a hiatal hernia, Hill grade 1. But if they have a Hill grade 4, there's this huge gaping hole from the diaphragm, and the sphincter is a little bit proximal behind that scope area here. So I can't readily visualize that. So a pitfall in measuring this association between gastric pressure and this EGJ opening is that I can't study it if there's a manometry catheter in the way. I can't insufflate the stomach with just the manometry catheter, and vice versa. If I have an endoscope in there, I can't insufflate the stomach with the manometry catheter in the way because that endoscope is blocking the pressure sensors. So we have a technology called EndoFlip, which is an impedance balloon, a distensible balloon that gives us a 3D morphology of the waist of that esophageal gastric junction. And we fill this balloon with saline, and we can kind of get a sense of the diameter of the lower esophageal sphincter and when it relaxes. But the same problem applies. I can't have an endoscope in the way here with this balloon here. So one of the thoughts I had was we create a overtube that slips over the scope with a distensible balloon, and we measure the delta of the esophageal diameter as we insufflate the stomach and see exactly where that point of where that lower esophageal sphincter relaxes to get an adjunct measurement of how at risk this patient is for reflux disease just on their endoscopy procedure without having to do that 96-hour Bravo test and pH, which takes 4 days to come back.
Sorry to interrupt.
Yeah.
So darn interesting.
Yeah.
What are the contents of the stomach? Is it filled with a liquid phase? Is it liquid solid? Or is there gas? Is there gas in between?
Yeah, so when we look in endoscopy, right, we tell them to fast because we don't want them to aspirate. So when we look in, the stomach is empty, ideally. But we don't know on a physiologic standpoint what is in there, because if we put a scope down with a stomach full of food, they may aspirate that, and anesthesia isn't too happy about that.
Maybe we can talk about that.
Yeah. So that's one of the ideas. And then if gastroesophageal reflux disease is severe enough, it can get up to the throat, and people can start complaining about vocal cord irritation, dysphonia, hoarseness, dysphagia, difficulty swallowing, throat clearing, or chronic cough. And there are certain metrics that we have, certain clinical signs that we weigh, what their BMI is, do they have a hiatal hernia, do they have a lot of regurgitation. Male sex has been predisposed to having reflux as well. And it can kind of give us a probability of reflux, but it's really hard to kind of link these symptoms to true acid reflux evidence reaching up to the throat. So the last aspect of reflux diagnostics that we can explore is impedance, which in addition to pressure sensors, we have impedance sensors that are paired that measure the flow of electrons between one another. And in impedance in a liquid bolus, there's less obstruction for these electrons to flow. So in a liquid bolus, as someone is swallowing, you have a transient drop in your impedance. While if they're actively belching air or there's nothing in their esophagus, the impedance is higher. On the manometry catheter, we have the impedance arrays in this sensor, two paired along with the pressure sensors. So you get impedance readings at different levels of your esophagus as well. And we can measure that and tell if this bolus is going antegrade down the esophagus or it's refluxing back up to the stomach based on the impedance values. So these plots are impedance values. When someone has a reflux event, you see that drop in impedance from the bottom sensor first. As it comes up, the rest go down. When someone is swallowing a liquid bolus, you see that impedance drop from up top as it passed through the stomach. And pathologic, if we're seeing a study greater than 80 reflux of retrograde events, that's more classic for an acid reflux patient. And on manometry, we have a signal for impedance and can tell if people are clearing the stuff that we have them swallow by their impedance signal. Purple is an indicator of low impedance. So on the left, it's someone who cleared their esophagus after swallowing. No purple signal is after that peristalsis wave. On the right side, you see someone with impaired esophageal motility, and you see a bit of that purple impedance level still hanging out. They didn't appropriately clear their esophagus because of poor motility. So that's one aspect, but people have also been using impedance as a sense of how irritable or damaged the esophageal mucosa is. Because over time, if you have a lot of chronic acid exposure, that can lead to damage of the mucosa. And the lining of the mucosa can lead to these gaps, causing more ability for these electrons to get through the different sensors and talk to one another. So we've studied people in their baseline impedance without swallowing or having reflux, and their baseline impedance is lower than someone who does not have reflux, suggesting that there may be acid exposure causing these breaks in the esophageal mucosa that may lead to these lower impedance values at baseline. And people have studied that with rabbit esophageal mucosa as they expose the esophageal mucosa to more acidic environments. We see on electron microscopy that there are these dilated intracellular spaces. So you can kind of imagine if those junctions between the cells of the mucosa aren't as tight, more reason for those electrons to flow and give you a lower impedance value, which can be a surrogate marker of acid reflux damage. So we don't really have great diagnostic criteria for reflux getting to the throat. A bunch of ENTs, gastroenterologists, surgeons met in Dubai, made a consensus for what they deem as someone who could test positive for lingual reflux disease. And basically, they just decided on having this impedance catheter in the throat for 24 hours. And if you have greater than one event, that classifies you as having the disease. Yeah.
Are you interested only when it comes to some distance of the esophagus, or is it only interesting when it comes all the way up into the mouth?
So I see both. So the ones in the throat are a little bit challenging because we don't have quite as much diagnostic capabilities to prove that. So we have a pharyngeal impedance probe that can sit in the throat and measure these values, but I don't know quite sure how that correlates with a true acid reflux event, or it could be something caused from something else, either asthma, postnasal drip, sleep apnea, things like that.
I think during the event, it's shedding some epithelial cells that you can't get into the mouth. Like if you could somehow collect an out content on a sponge and send it out for sequencing, do you think would be of any value to detect the presence of these epithelial cells?
So someone at Mayo kind of developed that. It was called a cytosponge, and it's more for developing a Barrett's esophagus. So it's basically like a collapsible sponge. They numb up the nose, they slide this decompressed sponge through. As it's exposed to acid, it expands, and they basically scrape up the lining of the cells to see if there's dysplastic cells or metaplastic cells from Barrett's. But it hasn't been used in the context of reflux disease in the throat. Okay, yeah, exactly. And so this is another pitfall, like, is impedance a true surrogate marker of acid? We can see that stuff comes up, but is it enough to cause damage to the mucosa that can lead to these symptoms that patients are endorsing? And based on this criteria, they designed 2 episodes in 24 hours. I can easily see that being a fluke potentially. So ENTs do a laryngoscopy in clinic. They numb up the nose. They don't go as far as we do, but they look in the vocal cords and see if there's any redness or erythema there. And some speech pathologists has deployed this FEES exam, flexible endoscopic swallowing study, where they use this consistency of dye and have the patient swallow. If they see this green matter in the vocal cords or by the vocal cords, these patients have a higher risk of aspiration because it's fallen into their lungs and could fall into their trachea to lead to issues. So impedance is probably the best thing that we have to see if reflux is getting to the pharynx, but the pharynx is very sensitive. I can't get biopsies of the pharynx. They'll be very uncomfortable if I do that. But I'm wondering if there's any imaging modalities that you have here at Beckman that can kind of get a deep visualization of maybe some microvascular injury that we can correlate these symptoms to, because I know you've done some work in the dermatology standpoint as far as like microvascular vessel damage from like port wine stains, things like that.
That's one thing, like, for spray or something like that, like, you could spray on the lining of the lining of the esophagus and then wiggle out. But I don't know what the spray would be, but.
Yeah, just saying, detective acid got up to there.
Or they sort of damage of the vocal or.
Okay. But oftentimes these patients are juggled between pulmonologists, ENT doctors, gastroenterologists, and we're trying to see, is this reflux or not? And then we don't really have a great answer for them. We put them on acid suppression medication. Sometimes they even get a RAP, and sometimes people don't get better too. So we're giving them a surgery for nothing. So we don't have a good diagnostic criteria for classifying this bucket of patients. And so kind of what I'm talking about, at least for the esophageal wall layers, I'm kind of looking at a depth of 200 microns. Clinically significant for our purposes, if there is an esophageal cancer that's greater than 200 microns, they need a surgery. But if it's less than 200 microns, just barely touching the submucosa, we can resect it endoscopically. So that's kind of the extent of what I would want an imaging modality to reach, depending on that.
Yeah, the OCT seems like
We have a check here, I think. We would help you.
Okay, gotcha.
I say we. Well,
Okay, gotcha. All right. And then the other aspect is this component of gastroparesis. And it's a diagnosis that I'm not quite clear. Some people, if you ask certain GIs, they say it doesn't exist. Some people say it does. But people come into our clinic, nausea, vomiting, early satiety, weight loss, they have regurgitation, and dyspepsia, abdominal discomfort. And it's believed to be from paralysis of the stomach, keeping food from emptying out appropriately. They have impaired relaxation from up top in the fundus area and impaired relaxation of the pylorus to let food go into the small intestine for digestion. As far as how the pacing of the stomach goes, that usually occurs in 3 phases. The predominant phase is phase 1, just a quiescent period where the stomach doesn't really do anything. Then you start having some irregular low churning contractions of lasting 20 to 30 minutes. And then to expel the stomach contents, you have these phase 3 reactions, 5 to 10 minutes to empty out the stomach, to get out of the pyloric sphincter and into the small intestine where it can be absorbed. And the best that we can have to diagnose gastroparesis is what we call a nuclear medicine gastric emptying study. So they go to nuclear medicine, they eat these liquid egg whites that are tagged with this sulfur colloid, and we watch and see how quickly it empties out of their stomach. A positive study is 4 hours, at least 90% of the meal has emptied. Less than 10% of stomach contents remain. And it should happen within 20 to 25 minutes for the liquid to start emptying. But it's not quite clear if this is a true reflection of gastroparesis. It's roughly 50, 60% that people with a normal gastric emptying study or normal gastric emptying study correlate with the symptoms they're describing. And this is really the best study that we have to kind of quantify what's going on in the stomach in some physiologic standpoint.
Papers about how the GLPs might be effective.
Oh yeah, it slows it down. Like before we kind of banned it from even doing endoscopy because the food was going to be stuck in there. Yeah, but we've gotten a little bit more lax on those requirements. And some proponents have been using functional MRI, 3D ultrasound to kind of get a more physiologic aspect of how the stomach is morphologically contracting in comparison in people with gastroparesis. However, these do kind of have the same caveats of the nuclear medicine study. It's a standardized meal. It's not what they truly eat at home. And there's no symptom feedback like the Bravo test where they could record their heartburn, chest pain, and we kind of look back and see if it correlates with an acid event. So it's kind of an examination in a vacuum. There is a component of people with dyspepsia and gastroparesis where they have stomach discomfort, all of the symptoms I described in the gastroparesis cohort, but the gastric emptying study is negative. So is it a truly separate entity, or is this gastric emptying study significant or not? And it only gives several hours of insight into how the stomach is working in this study. So one of the aspects I was thinking about, we have this Bravo technology. We can clip a probe in the esophagus for 96 hours. It stays there, it gives good data. Can we adapt this in the stomach with temporospatial sensors to kind of motion capture the stomach over a 96-hour period? They can mark whether they're having dyspepsia, stomach discomfort, are they having heartburn, are they not able to finish their meals? And we can kind of correlate that morphologically for what's going on in the stomach. So I know I talked with Dr. Choi a little bit about this. Maybe the mechanical engineers would be something to talk about if this, how feasible this is, but the thought I had. And then to measure other areas of the small intestine or the transit time between the small intestine and the colon for emptying, we used to have this smart pill. It was a capsule endoscopy that was taken off the market in 2023, but it gave us some good data. 5-day battery, it had a pH sensor, it had a pressure sensor, and it had a temperature sensor, and it could give us a sense of how quick or how slow things were moving for someone's GI tract. So the pH sensor could tell us whether it made from the stomach to the small intestine. The pH would go up, from the acidic contents of the stomach to the bicarbonate nature of the duodenum, as the pancreas secretes bicarbonate to neutralize the acid from the stomach. And then we can also tell the transition from small intestine to colon with a decrease in a pH unit of 1. The pressure sensor, they had this motility index with a complicated algorithm to sense whether the pressure was adequate in the small intestine and colon to propel the pill cam through. And they also had a temperature sensor as well. It was discontinued in 2023 because you can kind of imagine all of these 3 sensors. It was very expensive to produce, and Medtronic took it off the market. So right now, we don't really have any way, aside from a nuclear medicine whole body scintigraphy, which is very time consuming to be able to assess someone's small bowel motility. So people are trying to look at different alternatives, but one potential thought to have is having a lower cost pill cam device that can map the stomach in some form or fashion. We've used a component of FibroScan and ultrasound that is a surrogate marker for cirrhosis or stiffness of the liver, what I kind of mentioned in that first case. They put an ultrasound probe to the liver and then see the time it takes to bounce back to give us a stiffness marker of the liver, and it has good correlation to tell us if the liver is very stiff without needing a liver biopsy. And that's kind of changed the mapping and workup of how hepatologists work up their patients. There have been, I don't know if it's popular science or not, but people have done acoustic mapping of looking at sound waves bouncing off of different buildings to get a sense of a map of how things look. And the stomach is it's not too geometrically complex, and the rest is just a series of tubes. So I don't think it'd be too complicated to be able to map it in that regard. And we do have some experience in AI learning algorithms. Dr. William Carnes, he's been at UCI for a number of decades. He developed an AI algorithm with some postdocs at Stanford to get a computer AI-based detection algorithm for polyps. And they've actually sold it off, went to market. Unfortunately, it was replaced by the Medtronic brand, but we do have experience in some AI learning algorithms as well, at least in the polyp detection format. So it's kind of something I stumbled upon, but someone kind of mapped the Lausanne Cathedral in Switzerland by using this array of sensors with microphones, and they used these sound waves and changed the lining of the room with movable walls with good accuracy to measure the geometrics of that room. So I don't know what your thoughts about having a pill device. It can be complicated because that pill is moving. It's not stationary. But maybe have something to kind of map the walls of the stomach or the small intestine as it passes through the GI tract to get a sense of the morphology of things. Yeah, like a bat. Exactly. So we'll see. And then the last thing I'd like to talk about is inflammatory bowel disease. I'm not personally an inflammatory bowel disease specialist, but something my colleagues look after. And these are chronic conditions. It's a chronic autoimmune mediated response that attacks the GI lining of the tract. There's two different flavors, Crohn's disease and ulcerative colitis. Ulcerative colitis is classic for that. It starts at the rectum and has confluous inflammation until it involves the whole colon. While Crohn's disease, it develops in patchy areas of the colon and the small intestine and can manifest potentially anywhere in the GI tract, while ulcerative colitis is pretty much confined within the colon. And we don't know why this happens. We have very good treatments to suppress the immunosuppression, the inflammation with immunosuppression, but there's no quite clear-cut role for why this inflammatory response occurs. We have some hypotheses. There is some familial component, but there's no clear genetic link. And we've actually found that people who emigrate to the United States from their home countries where they have their standard diets, they eat the Western diet, and there's a more increase in epidemiology of these people having IBD from these people exposed to Western diets from their natural diet. So every year, there's a new IBD treatment on the market. It's a very lucrative market for the pharmaceutical industry. And we have good treatments to suppress the inflammation response. We have different medications that can keep the lymphocytes from getting out of the lymph nodes to get into the bloodstream. We have, that's ozanimod, etrasimod, the S1P receptors. We have vedolizumab, which is an anti-integrin inhibitor, which keeps the lymphocytes from getting out of the blood vessels into the GI tissue. And then we have our mainstays, the anti-TNF inhibitors that suppress the inflammatory cascade from signaling interleukin antibody damage. And we have more localized targets for specific interleukin cytokines with ustekinumab, risankizumab, all these mAbs, antibodies, monoclonal antibodies. But the point is that it's not curative. It's a lifelong therapy. We can put them in remission. They do well, but they need to be on these medications lifelong because we don't have a cause for why this inflammatory response occurs. Potentially, but we see TNFs, IL-12 throughout the body. And one of our mainstays, if they're not reacting to our medication, like they're hospitalized for an IBD flare, we give them prednisone. We just suppress everything to get them under control. So one of the proposals I had is failing if everything else, ideas didn't captivate you, we have a large tissue data bank available. So in our diagnostic endoscopies, we readily get esophageal, stomach, small intestine, colon tissue in our diagnostic exams. And we actually have a biospecimen repository study that was just launched. So when we get biopsies, we can actually reserve some of that tissue outside of the clinical indication for research labs to look if they're interested to study these tissues a little bit more. And one of the curious thoughts that I had was, is there a difference between the lining of the colon in people with IBD and people who don't? And is there some risk factor metric, some characteristic of the cells there that predispose them to getting this inflammatory response, whether it be a microbiome aspect, a mechanical shear stress from exposure from a Western diet? We don't quite know yet, but that's one of the aspects I was considering interesting. So summary, can we visualize upper GI bleeding with infrared imaging? Can we measure gastroesophageal reflux with an adjunct therapy by measuring that sphincter relaxation to gastric pressure? And can we quantify laryngopharyngeal reflux based on advanced imaging modality to see if there's acid exposure and damage going on within the pharynx? Gastroparesis is a poorly understood condition, but we need a little bit more diagnostic modality to see what's happening physiologically as people are eating their diets outside of the hospital and if they're emptying out appropriately. And then IBD is not curative. At best, we can suppress the inflammation, but they need lifelong treatment. So those are the ideas I had. These are basically my shower thoughts I have when I see these patients in clinic. And I'm happy and enthusiastic to see if we can collaborate on some of these ideas that I had. And of course, I'm open to any ideas that you might have as well as regarding the GI tract, and I'm happy to work with you going forward. So I work in Orange Monday, Tuesday, Thursday, Irvine Wednesday and Friday. I'm here at the new WEN Center in Irvine Wednesday and Friday, which they just opened up, and they're going to open up the Irvine Hospital at the end of this year as well. So any questions? With that, I'll end.
Yeah, I have one. Any diagnostic challenges about gastric lymphoma?
So it depends on what type of lymphoma it is. So there's a certain type of lymphoma called malt lymphoma that is related to H. pylori infection. So if we see that, I actually saw a patient yesterday with malt lymphoma with active H. pylori infection. If we treat the H. pylori infection, that malt lymphoma usually resolves on its own. If they have another type of lymphoma, that may be more of a bone marrow aspiration assessment. If that involves the gastric wall in any sort of action, we have an endoscopic ultrasound that can look at the depths of the tissue layer to see the involvement of that tissue. But usually it's a little bit more difficult to get biopsies of that because it's not a solid tumor cancer.
Elliot, I'm sorry, I have a hobble across here.
Okay.
I got like 20 ideas I want to talk to you about.
Okay.
Some are ridiculous and some I.
Yeah, I like ridiculous. All right, thanks for your time.
Thank you, incredibly.
All right, thanks for your time. Appreciate it. Anyone else?
I guess just think about
Yeah.
it logistically, so in terms of,
Yeah.
so we have a lot of, we have a lot of
Hmm.
technologies in-house that are relatively clinic ready.
Yeah.
And then obviously,
Yeah.
then
Yeah.
there's probably a lot of work that would probably also have to be considered as being done,
Yeah.
ex vivo samples and things like
Yeah.
that.
Yeah.
I guess at the one center, for instance, is it relatively, how do you do in terms of the workflow, in terms of being and we have like an investigational device that we developed or something to get it into the clinic for, basically for some pilot studies.
Yeah, I mean, it just has to be IRB approved,
Sure.
yes, but I don't think like if it's compact enough and we can apply it in the endoscopic room and like say if we wanted to like isolate some imaging from an endoscope, I don't see that there wouldn't be any challenges, I don't think.
Okay. And then for I guess with so you mentioned the biospecimen, the tissue bank.
Yeah.
So for some of the, do you think that there's tissues that would be available to do some ex vivo testing with some, like in terms of reflect some of the, that would basically be samples that would reflect the disease states? I think like the reflux, for instance.
Yeah, so I mean, we get, if someone has Barrett's esophagus, we always get biopsies, look for dysplasia. If someone has inflammatory bowel disease and we're checking them to see if they're in endoscopic remission, we get biopsies of the different parts of their colon. So we readily get them from a diagnostic standpoint, but they can reserve some of that if those are some of the disease states you're interested in studying.
Okay.
But I was particularly
So
interested.
they're restricted to like biopsy size samples, not like anything larger.
So you would have to ask the surgeons for that. It applies to the surgeons too, but you can ask the colorectal surgeon if they resect like a stricturing IBD case, can you get some of that tissue? But that database applies throughout the UCI clinical campus.
Impedance measured in the tummy tray, going on patients on different positions, maybe in the femoral bags, stand up or.
So in the manometry study, we study them in supine and upright positions. And the physiologic studies in the past, there has been an association for people to spontaneously belch more if they're in the upright position. It's because gas rises faster than liquid. And so there is a certain aspect of the upper esophageal sphincter and that it relaxes to allow you to vent gas. But when reflux comes up, ideally it should clamp up. So just by the rate of how quickly it passes through the esophagus, if it's an air reflux event, your US usually relaxes, while if it's a reflux event, it usually shuts off as an evolutionary mechanism to prevent reflux from getting into your airway. But and with that 24-hour impedance test, So they leave the hospital with that probe. So they sleep with it, they walk around with it, and then they mark whenever they're having heartburn, and then we look at the study, see if it has a pH correlation. Right.
This might sound like a stupid question.
No,
but
no stupid
when
question.
you have an acid reflux,
Yeah.
of course, you feel like there's a burning sensation,
Mm.
right? So I wonder if there's a temperature increase in like the area when the acid actually hits, and
Yeah.
whether or not you can use thermal imaging, which is one of the
Yeah.
technology you're looking into to track that through
Yeah.
the esophagus.
Yeah, so I don't know if there's are you talking about whole body temperature or the actual esophageal mucosa?
It's just within the esophagus, because I think one
Yeah.
of if I understand correctly, you like to track where the acid has gone.
Yeah.
Whether or not it's like down here or whether or not it goes
Yeah.
up to the throat.
Yeah.
I wonder if you can do thermal imaging and see whether or not the temperature correlates with the acid level.
Yeah, so there may be a transient change in that there is a hypothesis that people with chronic reflux disease can be at risk for cardiovascular events. It can increase your blood pressure, leading to more prolonged hypertension. That can lead to coronary artery disease in the long term. One of my old PIs was actually trying to study a way to physiologically measure blood pressure non-invasively while injecting acid into their esophagus and see if there's a transient change in that. But we couldn't find the right modality for that. In terms of the actual acid exposure, usually we see the hallmarks of the acid damage, that esophagitis I showed you in that picture, those breaks, that erythema. So by that time, that temperature response may be a little bit attenuated at that point, but I'm trying to see if there's a lasting response because there is some chronic damage that we see on those dilated intracellular spaces on electron microscopy. Anyone else?
So you had mentioned like a 200 micron, I think, depth, and so you know we had we brought up optical coherence tomography, which
Yeah.
I think seems pretty well suited for that. But I want to learn about multiphoton microscopy. I mean, at least doing because you all have beautiful images of the skin, pretty superficial depths, but it's but what I'm wondering about is just the cellular structure itself. Do you see it compromised? You might not have to go to the deep.
Yeah, 200 is probably a bit over the number, maybe 150 is the maximum, and the attenuation is probably at 20%. That's it, yeah.
Yeah.
Yeah,
this case it's strong point.
Yeah, we're in the endoscope, we're in the lumen of the esophagus.
I mean,
Like,
imaging, that's a trickier part.
Yeah, we'll give it a try on the lab.
And that's what we're asking. Yeah. Because you're right, you know, a lot of technologies, obviously for initial evaluation for a lot of things, skin is relatively, it's obviously very acceptable, and so there's a lot of places that have been evaluated on cutaneous tissues, but I think
my question to you is, can you apply your technologies through the endoscopic camera though?
so we tried that with at least with our tech, and I think it's kind of mixed results.
Okay.
Like the bronchoscope sort of technology worked about, you know, basically we had the camera on the back end.
Okay.
Seemed to work a lot better because we could control that camera.
Yeah.
I'm not saying it's not, it's not, definitely not saying it's impossible. But like with some of the other technologies, some of them already being ready-made for either to be used with, like in the working channel endoscope, or you know they're they're intravascular. So I think, unfortunately, John King's group's not here, but I think there's probably a lot that can be. There's a lot that they've done that could translate to several of the things that you're talking about.
Okay, great.
Even also like some of they've done like airway mapping, for instance, with the technology. So if you're trying to do any sort of mapping of the lower esophagus or stomach might be tricky because the stomach's constantly moving. I think. So as far as I know.
Yeah.
So, but it's definitely worth having a conversation with John Peng.
Okay.
And I think Sean as well with this photo, with some of these acoustic technologies.
Okay, yeah. I'd be definitely interested in talking about them.
And any other questions or anything for Elliot? Yeah,
All right. Yeah, thanks for your time.